Venous stasis. Junho Janyam D. Incidence/prevalence and YOPS coverage. It is estimated that more than 80 million Americans suffer from some form of venous disorder. Up to 13 million people in the U.S. suffer from CVI. Peak incidence occurs in women aged 40 to 9 and men aged 70 to 79 years. Statistics show 1 in 3 Americans over the age of 45 is affected by vein disease, and of those, only 4% are being treated. Annual healthcare cost in the U.S. to treat CVI is about $3 billion. About 2 million workdays are lost per year due to venous ulcers. Varicose veins. More than 24 million Americans have varicose veins. Up to 50% of women have varicose veins, while 24% of men aged 30 to 40 and 43% of men over 70 have varicose veins. DVT/PTS. There are over 200,000 new cases of DVT each year in the U.S. The incidence of pulmonary embolism in patients with DVT ranges from 5 to 20% and can be fatal. After an episode of DVT, 20 to 50% of patients develop post-thrombotic syndrome within the first 2 years. Venous stasis ulcers affect 2.5 million people in the U.S. An estimated 500,000 persons are newly diagnosed each year. Venous stasis, how? Mechanics, structure, inflammation, pressure. Obstruction, DVT. Function, transport blood back to the heart. Prevent intravascular volume overload. Anatomy, tunica intima, endothelium with BM and elastic lamina. Produces endothelium-derived relaxing factor and prostacyclin. Tunica media, circumferential SM. Maintains venous pressure gradient. Tunica externa, collagen. Stability. Valves, venous valves, one way. 2 cusps of CT skeleton covered by endothelium. Closure at greater than 30 cm per second. Exception, IVC, common iliacs, portal, cranial sinus, lower extremity. Venous hypertension. Hydrostatic pressure versus mechanical/muscular pressure. A.K. Tassiopoulos et al. 1,153 cases of ulcerated legs and venous disease. Reflux in superficial, deep, and perforating veins. Incompetent valves. Valvular dysfunction. Physical damage, splitting, tearing, thinning, adhesion to wall. Reduction in number. Not age-related. Monocyte and macrophage infiltration. Overexpression of intracellular adhesion molecules. Wall hypertrophy, disruption of collagen synthesis, and destruction of extracellular matrix proteins. Shear stress and inflammation. Pulsatal venous blood flow. Valve closes, vortical greater than pluminal. Minimal shear stress. Low shear stress starts cascade of inflammatory signals. Risk factors: genetic, more in females, hormones, pregnancy, age, greater than 50. Progesterone, estrogen. Pregnancy. Age, greater than 50. Greater height. Prolonged standing. Obesity. Signs and symptoms: telangiectasious reticular veins, varicosity. Thrombophlebitis. Hyperpigmentation. Bleeding from clusters. Ulceration. Aching. Heaviness. Early fatigue. Edema. Itching. Restless legs. Cramps. Physical exam, diagnostic tests. Palpable veins. Perthes test. For deep venous patency. Tourniquet and walk. Brody-Trendelenburg test. For superficial vein and valve patency. Venous filling time, normal within 35 seconds. Duplex ultrasound. Venography. Classification, C. P. Clough et al. J. of Vasc Search 2004. Clinical classification. C0, no visible or palpable signs of venous disease. C1, telangiectasies or reticular veins. C2, varicose veins. C3, edema. C4a, pigmentation or eczema. C4b, lipodermatosclerosis or atrophy blanche. C5, healed venous ulcer. C6, active venous ulcer. S, symptomatic, including ache, pain, tightness, skin irritation, heaviness, and muscle cramps, and other complaints attributable to venous dysfunction. A, asymptomatic. C. Etiologic classification EC, congenital EP, primary. S, secondary, postthrombotic. N, no venous cause identified. Anatomic classification. As, superficial veins. Ap, perforator veins. Ad, deep veins. Am, no venous location identified. Pathophysiologic classification. Basic SEEP. PR, reflux. PO, obstruction. PRO, reflux and obstruction. PN, no venous pathophysiology identifiable. Treatment: compression therapy, drug therapy, surgery. Stockings, Unasboot. Drug therapy. Surgery. Compression stockings. Worn during the day. Elastic stockings with adjustments and pressure. Lower pressure stockings, 20 to 30 mm Hg, for edema and DVT prophylaxis. Higher pressure, 30 to 40 plus mHg, for ulcers and significant venous disease. Operator dependent. Difficult to put on. Physical impediments/comorbidities. 50% of patients were unable to them on alone. 30 to 65% non-compliance noted in clinical trials in venous centers. Efficacy of compression therapy. 22 trials comparing healing of venous ulcers using compression stockings. Compressive therapy more effective than non-compression. Higher pressure were more effective than lower. Multi-layer compression was better than single-layer bandaging. 466 patients with a healed ulcer. Continued use of compression stocking reduced reoccurrence within 3 to 5 years. ISCHAR study, 500 limb trial that compares surgery and compression versus compression alone for ulcer treatment. Combination therapy had lower rates of reoccurrence of ulcer at year 4, 24% versus 52%. Drug therapy: pentoxifylline. PDE4 inhibitor that increases intracellular CAMP and stimulates protein kinase A activity. Reduces blood viscosity and decreases platelet aggregation and thrombus formation. Variable efficacy, more invasive sclerotherapy. 0.2% sodium tetradecyl injected directly into spider angiomas and smaller superficial varicosities. Complications, less than 5%, allergic reaction, hypo/hyperpigmentation, local skin necrosis. Endovenous laser ablation of saphenous vein, EVLT. Surgical excision of veins, stripping. Efficacy meta-analysis of 64 studies, 12,320 legs. Annihilus ablation via duplex US. Follow-up to 5 years. Success rate of EVLT highest after 5 years. Complications, DVT, less than 3%, local bruising and pain, paresthesias, foam emboli, stroke.